to Health Hour, a session for you by Black doctors, hosted by the Caribbean and African Health Network. Ever sat in a doctor's office thinking they just don't get it? Or search for health advice online, but you can't understand it? Felt unheard? You're not alone, and you found your solution with Health Hour. Every Saturday at 11 a.m., this is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Hello, and welcome to the Health Hour. So, I am Ijeoma Chibuzo, and I'll be hosting today. I am a consultant urologist at Manchester Royal Infirmary, and I have got with me Professor Frank Chinegwundoh, and our topic today is prostate cancer. Now, this is something that is such a hot topic amongst our Black communities, and it seems so imperative that we discuss this in depth. So, my honorable guest, Professor Frank Chinegwundoh, you are highly welcome, sir.
Thank you.
Your accomplishments are innumerable to prostate cancer. For at least 30 years, you have been in BOTS in the NHS in the UK. Your process study that identified that Blacks are at much higher risk of prostate cancer was a landmark study. So I encourage everybody who is here to listen. Tell us where you're coming from when you're contributing to the chats. And we have a lot to hear today and a lot to learn. Professor Frank is a member of the Order of the British Empire. He has been honored by the United Kingdom, by the monarchy, and we are so proud to have you here, as well as honored to have you here. Welcome.
Thank you very much.
So I shall hand over to you, and please educate us.
Sure. It's a pleasure to be here. I'm actually in Enugu in Nigeria, so I hope the Wi-Fi holds up for the next 45 minutes to 1 hour. Can I start sharing my slides?
Please go ahead.
Okay, I did have them up earlier. I think they were unshared.
And just while you're sharing your slides,
sure.
Oh, wonderful. They're up now and we can see them.
Yeah. So thank you for the opportunity to share some thoughts and some learnings, predominantly about prostate cancer. And why prostate cancer? Because it's the commonest cancer of men now, and it's common all over the world. So before getting into the detail of prostate cancer, I thought I'd just start with a few generalities. So, for example, what is cancer? And then I wanted to introduce the concept of screening before going into prostate cancer, the signs, the symptoms, the treatments, and whether we should be screening for prostate cancer. So the first thing to clear up is that people often ask me, what is cancer? Because they hear this term cancer, frequently, and some people are a bit unclear as to what it is. So just a brief slide about cancer. Every organ in the body is made of these tiny building blocks that we call cells. And these cells grow in an ordered fashion and then they die and they're replaced by new cells. A cancer occurs when this growth gets out of hand, and instead of an orderly growth and dying and regrowth and so on, these cells, these cancer cells, these abnormal cells just carry on growing, proliferating, and the problem is when they spread, they depress the bodily functions, and ultimately that leads to one's demise. So it's abnormal growth of cells. Now, because cancer it's such a major problem in the UK. Some years ago, the government had this program called Be Clear on Cancer, because one of the things that's common in the UK and it's common in Africa is late presentation. In other words, people come and they're diagnosed with the cancer too late for cure. So this is one of the things that the government did some years ago, was have a campaign called Be Clear on Cancer. So, for example, it was trying to alert the public that if they had certain signs and symptoms, they should go and seek medical attention. So, for example, if you're coughing up blood, you should go and seek help. If you've got abdominal pain, diarrhea, blood in your poo, again, this goes on for more than 3 weeks, seek help. Similarly, with cervical cancer, we have screening for this, where women are invited at regular intervals to have their smear tests. When it comes to the testicle and the breast, the emphasis is on self-examination for lumps. But the other thing that became apparent to me is not everyone understands the purpose of screening. So, for example, there's many women that I know who, when invited to have their screening for breast cancer, don't turn up. And when you talk to them, it's because they don't understand the concept of screening. So I just thought I'd say a few words about screening, because many people, that you go to a doctor when there's something wrong with you. You don't go to a doctor when there's nothing wrong with you. And so the concept of screening is certainly alien to some people. So the whole focus, the whole point of screening is you take a group of healthy people and you put them through some tests to see if they may have whatever cancer it is that one is looking for. And the whole idea is that if you can find a cancer, wherever it is, at an early stage and you treat it, the outcome is much more favorable than if you find the cancer late. So you take a group of people here in green, you put them through a screening test. So for example, if we're looking at the prostate, this would be the blood test, PSA. If we're looking for early breast cancer, it would be a mammogram. If we're looking for early cervical cancer, it would be a smear. So you put people who are apparently healthy through some sort of screening test, and the orange are those people that your initial screening test shows some abnormality. Then you then put them through further tests. Some of those will turn out to have cancer and others not. So the purpose of screening is to find disease early where there are no signs or no indications that that person may have cancer. So at least in the UK, we screen for bowel cancer, cervical cancer, breast cancer. We started lung cancer screening, but the commonest cancer amongst men is prostate cancer, and we do not screen for prostate cancer. Why? Perhaps we can discuss that towards the end. So again, before talking about prostate cancer, it's good that all of us understand what the prostate is. And I'm aware that there's many lay people that are going to be listening to this. So I always start off by asking these basic questions. What is a prostate? Where is it? What does it do? And what can go wrong with it? If this was a live audience, I'd be asking people these questions. So what is a prostate? Well, the prostate is the size of a walnut or a large cola nut, for those of us in Africa. And it's about this size, and it sits underneath the bladder, okay, and the water pipe connected to the bladder to the penis that we call the urethra runs through the middle of the prostate. So this prostate, what does it do? You know, what's its purpose? So the thing about the prostate is that it's a sexual gland. It produces fluid. Okay, most of that seminal fluid is prostate fluid. So when the man ejaculates, what comes out is semen. That semen is a combination of a tiny amount of actual sperm from the testicles, but it's mostly prostate fluid and fluid from another organ called the seminal vesicles. And what that prostate fluid does, its purpose is to nourish the sperm. So when the sperm are in the vagina, heading towards the egg to fertilize the egg for conception purposes, the energy for the sperm is derived from the prostate fluid. So without a prostate, you would be infertile. So it's a sexual gland. The second function of the prostate is because the water pipe runs down through the middle of the urethra, runs down through the middle of it. It has a role in regulating the flow of urine in a man. And most men will recognize as they age, the force of the urinary stream becomes slower. And that's because the prostate begins to squeeze the urethra that runs through the middle of it. So we know where it is, and we know what it does. It's a sexual gland, and it helps regulate the flow of urine. Now, the third thing, the fourth thing is what can go wrong with it. Essentially, there's three things that can go wrong with the prostate gland. It can become inflamed, it can become enlarged, it can become cancerous. And those three things are not mutually exclusive. These three things can coexist. Generally speaking, the prostate inflammation that we term prostatitis occurs in young men, so 20s, 30s, and 40s, where the prostate gland becomes inflamed, and the man experiences pain, may experience some sexual difficulty, may experience frequent passing of urine. 1 in 7 men in that age group will develop inflammation of the prostate, prostatitis. But we're not focusing on that today. We're focusing more on the enlargement and also on prostate cancer. This is a schematic showing the bladder, and underneath the bladder is the prostate, and it's got a channel through it, which is where the urine is expelled. The top picture shows the normal prostate. The bottom picture shows that the prostate gland has enlarged outwards and inwards. This happens with aging, and it squeezes the urethra that runs through the middle of it. Now, most men, particularly over the age of 45, 50, 55 upwards, most men will have this enlargement of the prostate that occurs naturally with aging. Okay, this is separate to prostate cancer. Okay, so most men, the prostate will enlarge, and they will experience symptoms associated with that enlargement, which we'll come to shortly. But if we're going to have a focus now on prostate cancer. Prostate cancer is the man's cancer. The equivalent cancer in women is breast cancer. And there's certain similarities between breast cancer in women and prostate cancer in men. Namely, they are under hormonal influence. So estrogens fuel the growth of breast cancer. Testosterone fuels the growth of prostate cancer. And as I said earlier, prostate cancer is more common in Black men, but affects all men. It's either the first or second most common male cancer, worldwide. So it's the most common cancer in men. 1/4 of new cancers in males is due to prostate cancer. there's increased prostate cancer diagnoses, largely because of men being more aware of the PSA blood test and getting themselves tested. Although we do think there's also a true increase in incidence, not just we're finding more of it. I won't play this video, but a few years ago, the BBC took me to Nigeria to try and raise awareness about prostate cancer. But I won't show the whole clip for purposes of interest of time. So when I did this research, it must be 20 odd years ago, showing that Black men had a twofold risk compared to white men of getting prostate cancer. That led the NHS to pay attention and try and raise awareness of prostate cancer in the Black community. And this was some years ago. There were posters throughout London, 1 in 4 Black men will get prostate cancer. And it was to make particularly Black men aware of this, and so they could talk about this to their GPs and get themselves the PSA blood test. So just a few facts about prostate cancer. It is higher in Black men. Often I'm talking on the radio program to Black men, and they question whether this is actually true. They question whether we're trying to stigmatize Black men, or it's some sort of conspiracy against Black men. And I say, no, it is not. You know, I did research where essentially I looked at all the prostate cancer diagnoses over a 5-year period, worked out these men's ethnicities and related that to the percentage of Black, white, and Asian men in the community, and found out that actually Black men had a 2 to 3-fold risk, and that risk is highest in the younger age groups. Asian men, and by Asian, for this purposes, we're talking about Southern Asian, Bangladesh men, Indian men, Pakistani men. Their risk is half that of white men. Okay? So Black men have 2 to 3 higher risk than white men. Asians have half the risk. Why is prostate cancer much more frequent in Black men? Remains elusive. Despite a lot of research throughout the States, the UK, throughout many different countries, trying to find out that confers that increased risk of prostate cancer. Interestingly enough, if you look at the transatlantic slave route, and you look at where those men were taken from the west coast of Africa to the Caribbean, to America, to find that's where the highest risks of prostate cancer are. So there's something about the West African diaspora that confers that increased risk. Is it genetic? Possibly, but we don't know. The other important fact is that on average, Black men are 5 years younger than white men when they develop their prostate cancer. And this is important for public health, because at least in the UK, one of the things that the National Health Service put out many years back was that if you're a man of age 50 and you're concerned about your risk of prostate cancer, you go and see your family doctor and get their PSA blood test. And I campaigned to say that's all very well, but Black men are younger. Therefore, it should be Black men from 45 years who are able to access the blood test through their family doctor, not wait until they're 50. And so this has now become accepted. So it's not just in the UK that we're trying to raise awareness. This is from 2019. One of the charitable organizations in Nigeria, Project Pink Blue, have regularly been putting on walks. This is in Lagos to raise awareness of prostate cancer, and saying to men, whether they've got any urinary sexual symptoms or not, they should get themselves tested. So the risk factors for developing prostate cancer: increasing age. So it's uncommon under the age of 40, and the risk increases with age. Probably peak age is probably 60s to 70s. So it's, but I say we should start testing Black men from the age of 40, other races from 45 onwards. So I've mentioned about ethnic origin being linked with prostate cancer, and very importantly, family history. So prostate cancer is often familial. So in other words, if your father has prostate cancer, or your brother or an uncle or something like that has prostate cancer, your risk is going to be increased. So if your father has prostate cancer, your risk is double compared to a friend whose dad doesn't have prostate cancer. So if you combine being Black and you combine the family history, you see that the risk of prostate cancer is high. The other thing to note, which is less commonly known about family history, is that the family history of breast cancer or ovarian cancer on the maternal side also increases your risk as a male of having prostate cancer. So if I see someone in my clinic, I not only ask them about the paternal side, or brothers or so on, I ask if their mother's had breast cancer, or do they have a sister with ovarian cancer, because that also plays into your risk profile. Other things on the slide, you can see I've mentioned diet, alcohol, ultraviolet exposure, smoking, pattern of sexual behavior. The jury is out as to how much these things influence prostate cancer. It does, however, seem that if you're a smoker and you get prostate cancer, it will be more aggressive. Obesity is associated with an increased risk of aggressive prostate cancer. Diet, it seems that if you have a diet that's very high in meat and fat, it can increase your risk of prostate cancer. Conversely, lots of fresh fruits, lots of vegetables, reducing dairy products, we think confers some protection. Pattern of sexual behavior is an interesting one. It turns out that the more unprotected sex with multiple sexual partners when you're young will increase your risk of prostate cancer when you're older. So if I'm talking to a group of young men, I say, wear a condom. The other thing that increases your risk of prostate cancer is sexually transmissible diseases when you're young, so 20s or 30s. That seems to increase your risk of prostate cancer when you're perhaps 50 or 60 or so on. The other interesting thing about sexual behavior is that there is a suggestion that the more times you ejaculate, the lower your risk of getting prostate cancer. One study suggested a figure of 21 ejaculations per month reduced your risk significantly compared to less than 21 ejaculations a month. How does prostate cancer present? It may present with no symptoms whatsoever. And this is where I think we should be screening men, particularly Black men. You may have no symptoms whatsoever, but still be harboring a cancer of the prostate gland. And the importance of this is that if you find it early and treat it, the outlook is incredibly favorable. We're talking about 98% cure rate if you find it early. So you may have no symptoms, or you may have the same symptoms as the ordinary benign prostate enlargement. So I mentioned earlier that virtually all men, as they age, this prostate gland enlarges and begins to squeeze the urethra. And when that happens, there are several symptoms that the man may notice. So, for example, it's slow to start the flow. The stream is weak. You have to strain to expel your urine. It may take you a long time to do so. You may find that you're not emptying your bladder fully, so you've got to go again fairly shortly afterwards. You may develop retention, which is where you can't pass urine at all. or you may develop incontinence where the urine just comes out. You may have urgency, which means going frequently, well, not just frequently, but having to get there in a hurry. So when you get the urge that you want to pass urine, you can't hang about. You've got to find the toilet quickly and expel the urine. Frequent micturition. So the average man will pass urine between 7 to 8 times a day. So if you find you're going 10 times, 11 times, 12 times, that's too frequent. So that can indicate that you've got some prostate trouble. Getting up at night, this is often what drives men to seek help, is that they're getting up 2, 3, 4, 5 times at night and disturbing their partners. And I've lost count the number of men that I've seen whose partners have said to them, "You're disturbing my night, go and get yourself sorted out." So these symptoms are symptoms that can indicate some problem with the prostate. Not mostly it would be the ordinary benign enlargement, but at times these symptoms may indicate prostate cancer. So you can't tell by the symptoms, these symptoms, whether it's prostate cancer or the more common benign enlargement. The other thing that I will mention is that some men develop what we call hematuria, which is passing blood in the urine. If you pass blood in urine, you need to get yourself seen urgently. It could be prostate cancer, it could be urine infection, it could be bladder stones, but you have to exclude prostate cancer. And back pain, sudden onset of severe back pain can indicate prostate cancer that spread into the bones of the back. One of the things about prostate cancer is that when it spreads, it tends to spread to the bones. And so we do see men who have got no urinary symptoms, no erectile dysfunction, which is one of the things that can occur with prostate cancer. None of that, they just present with back pain or pain in one bone or the other. And recently in the UK, there's a very famous cyclist called Chris Hoy, who's won 6 Olympic gold medals. So you can imagine he's super fit. He didn't have any of these symptoms of prostate enlargement. He didn't have any blood in his urine. He presented to his GP, his family doctor, at age 48 with sudden severe pain in his shoulder. And one thing led to another, and he was diagnosed with metastatic prostate cancer at age 48. That is prostate cancer that has spread to the bones. And in his case, it was the shoulder that was causing him the most problem. Now, for him, that's a personal disaster for him. We've got very, very good treatments indeed for controlling prostate cancer that spread beyond the prostate, but ultimately we can't cure prostate cancer that spread beyond the prostate. And one of the sad things about this famous cyclist Chris Hoy is that his grandfather had prostate cancer, his father also had prostate cancer, and when he went to his family doctor at age 42, asking whether perhaps he should start getting himself tested, he was kind of dismissed, only to come back 6 years later with severe bone pain due to metastatic prostate cancer. So if you have a family history, don't take no for an answer if you're seeking the PSA blood test. So what happens when we see a man with these urological symptoms? We examine the man and we run certain blood tests. I'll just say a word or two about the digital rectal examination. The prostate, as I said, sits underneath the bladder, and it also sits in front of the rectum. Therefore, if as a healthcare professional you introduce a gloved finger into the man's rectum, you can feel the prostate gland, you can feel the size, and you can feel the consistency. However, when it comes to the risk of prostate cancer, it's not an accurate test at all. The PSA blood test is far more informative as to the man's risk of prostate cancer than a rectal examination. In fact, so much so now that at least in most places in the UK, we've moved away from doing rectal examinations, except in very special circumstances. The most important thing we do when we see a man presenting with urinary symptoms is the PSA blood test, prostate specific antigen. This is a chemical made by the prostate gland, and if the level of it is raised in the bloodstream, that can indicate that there's some problem with the prostate. So in terms of our diagnostic tools, so for example, if I see a man who's been to his family doctor, he just wants to know about his risk of prostate cancer, perhaps he's black, perhaps he's got a family history, perhaps he's been to a talk about it, and he has the blood test, doesn't have to have the rectal examination, he can just have the blood test, and the PSA is higher than it should be. It should be less than 3 units. If it's higher than 3 units, it doesn't mean that he's got prostate cancer, but it means we need to run the test to see if he has. The PSA can be elevated in the bloodstream for a variety of reasons. It could be just to do with a big sized prostate gland. It could be he's got some sort of inflammation. It could be that he ejaculated the night before doing the blood test. There's various reasons why the PSA can be raised, but the most important thing for us as urologists is to exclude prostate cancer. So we do an MRI scan of the prostate gland, taking very detailed pictures of the prostate, and the radiologist, that is the medical specialist that looks at these images, can tell us if there's certain areas of the prostate on the MRI that look abnormal. And if they are, then we can target those when we do a biopsy. Nowadays, we do, at least in the UK, we do a transperineal prostate biopsy. In other words, we put the needle through the perineum into the prostate to take samples, and those samples go off to the lab to determine whether it's prostate cancer or not. Where is the perineum? The perineum is that skin that lies behind the man's testicles in front of the back passage. And that area is the perineum, and the prostate lies deep in there. And commonly what we do is we anesthetize that localized area with some injections. We pass an ultrasound probe into the rectum, we image the prostate on a monitor, and then using the images, we can direct our needle through the perineum and sample those areas of the prostate that are abnormal. So to make a diagnosis of prostate cancer, you've got to get tissue from the prostate and have it analyzed in a laboratory. You can't diagnose prostate cancer for sure just by means of a blood test or what the prostate feels like. So this is just, excuse the graphic nature of this. This is just showing how we do the biopsies. The man is on his back, his legs are up in the air. We anesthetize the perineum, which is underneath the testicles, in front of the anus, ultrasound probe in the back passage, injections to numb the perineum, and we put a needle into the perineum and take samples of the prostate gland. Depending on the size of the prostate, we may take anywhere from 3 to 10 to 20 samples, depending on what areas of the prostate look abnormal. So it generally takes us maybe 1 to 2 weeks to get the results back from the laboratory. And if it comes back as prostate cancer, then there are a variety of treatment options for that. Now, one of the things to say is that not all prostate cancers are the same. Some prostate cancers, the cells, when you look at them under the microscope, do not look very active. Other cancer cells look more aggressive under the microscope. So we grade the prostate cancer cells. It's what we call the Gleason grade, which goes from 6 to 10. And depending on the Gleason grade, depending on how aggressive those cancer cells are, will depend on the various treatment options for that man. Now, we differentiate. In other words, we put these men into two groups. One is the prostate cancer just in the prostate gland alone, and the MRI scan can tell us that. Or is there evidence that the prostate cancer has already spread into the lymph glands, or into the bones or into the liver, in which case they will go down a different advanced prostate cancer treatment route. Okay. So for these purposes, if we take a man who's got what we call organ-confined prostate cancer, in other words, the prostate cancer is just in the prostate gland, it's not anywhere else, and the cancer cells look not too aggressive, then we can offer the man what we call active surveillance. Active surveillance is where we don't put the man through any of the treatments below on the slide. We essentially monitor this man with a view that if it seems if the prostate cancer is becoming, it's increasing, then we can then offer them these radical treatments. So the type of man that we'll put under active surveillance is someone who's got perhaps we've taken 10 cores, 10 samples of the prostate, and only 2 show cancer. In other words, low volume disease. The cancer cells don't look very aggressive. The PSA is perhaps 6 or 7, so not that much above normal. So that group of men, you can just monitor them. You can check the PSA every 3 to 6 months. You can do an MRI every year. And if there's no change in these things, then they don't need to undergo radical treatments. And so not every man, of course, is going to be suitable for active surveillance. But if you are, then it's a perfectly safe thing. If the PSA is rising or there's something else to indicate the prostate cancer is becoming more active, then we wouldn't have missed the boat in terms of offering them these other treatments. And the reason for active surveillance becoming a treatment option is that it avoids the risks inherent in some of these other treatments that I'll discuss now. So for those men who perhaps are not suitable for active surveillance, perhaps they've got a lot of prostate cancer in the prostate gland, or the grade of the cancer is higher, then we can offer them a radical prostatectomy, radical external beam radiation, low dose rate brachytherapy, and more recently what we call focal therapies. So radical prostatectomy, this is a surgical procedure. Nowadays, at least in the UK, it's done with robotic technology. The operation is an abdominal operation. The surgeon sits at a console remote from the patient. The robotic arms are inserted through the patient's abdomen, and the surgeon can manipulate these robotic arms to remove the prostate gland without physically touching the patient. I think I may have a picture of that. Yes. So this is a robotic radical prostatectomy. It's complete removal of the prostate gland, not to be confused with surgeries that we do for the enlarged non-cancerous prostate, where we do surgeries by passing instruments through the man's penis. This is completely different. This is an abdominal operation. You can see the robotic arms, which are inserted into the patient's abdomen. The surgeon sits at a console. The robotic arms are attached to the console, such that the surgeon has a magnified view and is sitting comfortably and can manipulate the robotic arms, which is much more accurate than trying to use your hands physically in that man's pelvis. So that's radical prostatectomy. It's a very commonly performed operation. It's widespread throughout the UK. It's been introduced recently into Nigeria. So the disadvantage of radical prostatectomy is that it can cause erectile dysfunction, in other words, impotence, which is something that is disagreeable to most men. Although there are ways and means of getting out erections if they've been done away with radical surgery. The other thing that men fear about radical prostatectomy is urinary incontinence, which means the man has to wear pads. Most times that improves, but there is perhaps 1 in 20 where the urinary leakage is a long-term problem. Radical external beam radiation. Again, this is a very common treatment and it's widely available. You leave the prostate where it is. This doesn't involve surgery. This involves firing high energy rays, similar to X-rays, down through the pelvis, and these radiation beams hit the prostate gland and destroy the prostate cancer, without having to physically remove the prostate gland. So typically, this you have a radiation dose daily for up to four weeks. There are some regimes where this can be reduced to 2 weeks, but more commonly, particularly outside the UK, it's a 4-week treatment. Monday to Friday, you come to the radiation department, you lie on the couch, and this machine emits radiation for a few minutes. You're supposed to go home, come back the next day. So radical external beam radiation. Another option is what we call low dose rate brachytherapy. This is where you insert the radioactive pellets, radioactive iodine pellets, under general anesthesia as a day surgery procedure. These pellets lodge in the prostate gland permanently and give off radiation, which destroys the prostate cancer. So the side effects of therapy can include erectile difficulties, and can include having to go more to pass surgery. This is where you insert needles into the prostate, and through those needles you insert radioactive rods, and then you remove them when they've, after a few hours, when they've given off their dose of radiation. More recently, focal therapy, irradiate the whole prostate. You don't remove the whole prostate. You just target the particular area where the cancer is and treat it with high intensity focused ultrasound or with cryotherapy. The advantage of the focal therapies is that you get less side effects because you've not treated the entire prostate. And for the correct patient, it's a very effective treatment with very good long-term results. The long-term results of the various treatments are very good. You would expect 98% of men to be fine. This is 10, 15, 20 years hence. And nowadays, at least in the UK, I know it's different in most West African countries, but at least in the UK, most men now are diagnosed without any urinary symptoms on the basis of the PSA blood test. They may have symptoms the same as the benign enlargements, just a slow flow, the frequency, getting up at night and so on. Erectile dysfunction or blood in the semen can be a presenting sign of prostate cancer. If you've got advanced disease, then particularly to the bone, you may get severe pain. If the prostate cancer has gone into your spinal cord, you will get cord compression, which can lead to paralysis. We have a multidisciplinary approach to prostate cancer. So every patient that's diagnosed in the UK, there's a team discussion, surgeons, oncologists, radiologists, pathologists. So every man's case is discussed and a suggestion made as to what treatments may be suitable for that man. just coming towards the end now. This is just a schemata of how we deliver low-dose rate brachytherapy. The man is in the same position as if he's having a biopsy, except he's under general anesthesia, ultrasound in the rectum, in the back passage, so we can visualize the prostate on a monitor. And then through the perineum, we insert needles through which we insert the radioactive iodine seeds. So I'd like to finish off by saying that men, we need to know about the prostate gland. We need to know that we are at risk of getting prostate cancer, irrespective of whether we've got any urinary or sexual symptoms or not. If prostate cancer is caught early, whilst it's still confined to the prostate, the cure rate is very high. Indeed, I see many men who try various herbal remedies and need to come back sometime later when the prostate cancer has spread. One of the things that men are perhaps not so good at is actually talking about it. So we need to talk about it, not just talk about football and Arsenal are going to win the Premiership. We need to start talking about other important matters, such as prostate health. There are various, in the UK, black cancer charities that are always seeking support. Thank you.
Thank you indeed, Prof. That was very interesting, very lovely. And I have to say thank you to the wonderful audience because the questions have been flooding in. So do get prepared, Prof. Right, so we are going to take the questions that have been submitted. And somebody asked a question, why are Blacks more susceptible? Is it the inequity in healthcare or healthcare options? Is it low income? Is it reluctance to have an internal examination or a prostate exam? Is it the low level of information? And I'm going to join it with another question, which says, is it the vitamin D deficiency that Blacks experience abroad?
Well, I don't think it's to do with access to healthcare or those other things. The answer is that we don't know why. There's something biologically inherent that we haven't as yet identified. Vitamin D, vitamin D may be involved. Our hormones may be involved. Our genetics may be involved, but it's a biological difference. Now, when it comes to survival, that's when health equity comes in. If you don't know about your prostate, and by the time you turn up, it's already advanced, then you won't do so. You won't do so well. Access to treatments, sure, all those things are important in terms of the surviving prostate cancer, but in terms of actually developing it, there's something biological that we haven't yet.
Since you've touched on biology and genetics and all of that, there's a very interesting question that says, yes, people of Black descent are prone to prostate cancer, but this person works in pediatric oncology, and they've been noticing young children being diagnosed more these days with prostate cancer. And they're asking, is there something that can be done to, number one, can we explain this? And what advice can you give them to help them stop it happening in children, or even to recognize it early?
Well, I mean, that's outside my experience. I've not come across a child with prostate cancer, although I have heard of rare instances of perhaps someone of 17. But I've never seen, the youngest person I've seen with prostate cancer was 37. And, that's the kind of, even under the age of 45, under the age of 50 is uncommon in the UK. So I can't answer that question as to pediatrics. I've not come across prostate cancer in a under 18 age group.
Okay.
So I don't know how you could prevent that.
Right. Okay. So now the other questions are more on screening and how to prevent it. So in terms of prevention, since you've touched on that, questions are, can vasectomy increase the risk of prostate cancer?
No.
No.
That's a short answer. There's
Yes.
multiple studies, and the conclusion is that no, it doesn't increase your risk of prostate
And if
cancer.
I can extend that, some Black people would say they don't want a vasectomy because that might increase their risk of prostate cancer. So they want their wives to have oral contraceptives instead. So please continue.
It doesn't increase your risk. I think where that came from is that prostate cancer is so common. It's something in the UK, something like 62,000 men a year will get prostate cancer. Vasectomy is also very common means of contraception. So that's where this kind of story came from, because a lot of men with prostate cancer have also had vasectomies. But there's been lots of studies done now in various countries, proper epidemiological studies, and there is no link between having a vasectomy and having prostate cancer. So men, we can't use that as an excuse.
Right. Thank you for that, Prof. Still on issues related to sexual activity, you mentioned something about young men and sexual activity. There was a viral video going around saying men need to ejaculate more to prevent prostate cancer, and you're giving a different information. So please, can you touch on that a little bit more?
Well, what I said is that I think there may well be a link between how often you ejaculate and prostate cancer. It's just that this study out of Harvard, looked at this in some detail, and they came up with this figure of 21 ejaculations a month, which for the vast majority of men is not going to be achievable. But it would seem sensible to me that even if you didn't reach that number, ejaculating more rather than less may be protective. Certainly won't do you any harm in terms of your risk of prostate cancer.
Right. So someone's asking, what educational piece can be done regarding increased risk of sexual activities with young men and prostate cancer?
Well, it's a question of getting into those areas where young people are accessing, and I guess that nowadays has to be by social media. The thing about being young is that you can't foresee 30 or 40 years hence, and linking your behavior now to something that may or may not happen, when you're in your 50s or 60s. It's a very difficult message to get across, but at least raise that awareness, at least implant that seed, whether or not they take it up. So there are, I know that various faith groups have done work on this in terms of trying to educate their congregations. Certain charities, Cancer Black Care in the UK being one of them, regularly does outreach to the Black communities, just trying to raise awareness about prostate cancer, sexual behavior, as well as other health messages.
And just
yes,
for the next,
a lot more needs to be done.
Yeah, definitely a lot more awareness needs to be done. Yes. For the record, can you just give us some more of those Black prostate cancer related charities? Somebody's asking for more detail about them.
Well, in London, there's Cancer Black Care is one. You've got this one in Manchester. I think it's I Can Survive. This one in Bristol. I haven't got the names
Okay.
I'll have to
But they
find out
are
the names and
there.
perhaps
They are there.
let Kana. Yes, they are. Yeah,
Yes.
yeah. In Bristol,
And
Manchester, London.
London,
Yeah.
yes. And then, of course, there's Unified Prostate Cancer that is not just strictly for Black men. So there are other charities as well
Yes,
that deal with prostate
that's
cancer
right. Prostate, absolutely,
in
absolutely.
general.
Prostate Cancer UK, Prostate Cancer Research,
Exactly.
Tackle. There's quite a few.
Yes. And you mentioned something about Black men with family history starting to screen from the age of 40. Now, I have a two-part
Yes.
question here. So I'm combining different people's questions. One is saying that at their GP practice in Yorkshire, that they can't get it till they're 50. Another person is saying they were 69, about to turn 70, and it was a hassle getting it. So they are asking, one, how can it be universal that a Black person gets PSA at a younger age? And why is there seeming reluctance for practices to test early or offer a PSA?
Yes, this is one of the banes of my life that I've been pushing against for the last 20 years, actually. The problem stems from a document called the Prostate Cancer Risk Management Program. So this was a document I think first came out about 2011 that the NHS sent to every GP in the country, saying you can do PSAs in men over 50, even though they haven't got any symptoms. Took no account of family history, took no account of Black men. And we've been trying ever since to change that guidance. So GPs are going, on out of date guidance. So we have to advocate for ourselves and perhaps show some literature to the GPs to suggest that actually, if we're Black, we get it younger, therefore we should be have access to that PSA earlier than white men. It's an uphill battle. We've been I've spoken to Royal College of GPs on more than one occasion. I've written articles in magazines that they read, and we've done outreach to various GPs up and down the country, but there's a great many of them, and once they've got this idea, then it's very difficult to shift that.
And it's because
to get up to date.
Yes, and a lot of things are guideline based, just like you said. So teaching the people in the practice as well as the patients is so important. And the other question someone is asking, I think you've answered this. They're just clarifying the ages. And it's from what you said is 40 if you have a family history not only of prostate cancer, but other cancers, and 45 for other men. So I think we can skip that. Now.
Yeah, so sorry, I just say
yes,
that is my view. That is my view. The
right.
NHS view is still 50 and 45, but that's kind of behind the times. So my view, from having been dealing with this just by day in day out for the last 30 years, it's 40 is when we should start, not 50 or 45. But so it takes a while for the official guidance to catch up with actually what's happening on the ground.
Definitely. But it is a battle in progress. So still on the lifestyle activities.
Very much so.
Yeah. Still on the lifestyle activities. Someone's asking, what can they do to prevent prostate cancer? Is it diet? Is it lifestyle activity related? What can they do?
I say that what you can do for yourself to try and reduce the risk, as far as we know, is make sure your vitamin D levels are good. Okay, we think vitamin D is protective. What you eat what you eat and drink is important. So fresh fruits and vegetables we think are protective. Less red meat, more fish, more white meat. Tomatoes are good. Pomegranates good. Brazil nuts are good. All these things we think are protective. Dairy products, we think are bad. So less dairy, less red meat, exercise, keep your weight down, and do not smoke. And if you have multiple sexual partners, wear a condom.
With regards to vitamin D, somebody is asking if the vitamin D deficiency makes it more lethal, not just the risk of getting prostate cancer, but does it make it more lethal if you get prostate cancer?
I've not seen any data to suggest that. So, yeah, I don't know the answer to that, but I've not come across data that says that.
Okay, onwards from prevention, and we're going to testing. And someone's asking, a lot of people don't want a rectal exam. So are there other tests that can be done that don't involve a rectal exam that can help with the diagnosis of prostate cancer?
So I hardly do rectal examinations nowadays. I hardly ever do a rectal examination. I just do the PSA blood test. If a man is referred to me in my clinic with a PSA, raised PSA, I send them straight for an MRI scan. I don't do a rectal examination. The rectal examination is not going to preclude me from having to do an MRI. So why put the man through that? And interestingly, since we've stopped doing rectal examinations, at least in my area of East London, we're seeing more and more men coming forward because they can just have a blood test. So they don't have to have a rectal examination.
Okay.
So it's not necessary. Just get the PSA blood test.
Right. So on to treatment. So someone's asking, if it's got early, you've mentioned loads of the treatments. Could you explain them in a very simplified manner and what the quality of life of the patient who has these treatments looks like? Early prostate cancer.
Yeah, so you've got monitoring, so your quality of life is unaffected. Then you have to got surgery or some sort of radiation. Okay, those are the main treatments. Okay, surgery, radiation, monitoring. Quality of life depends on, well, the first thing to say is that actually the outcomes for those treatments are equivalent. So it's not that surgery is better than radiation, or radiation, whether it's external or the seeds, is better than surgery. The outcomes are the same. Quality of life depends on whether you're fortunate enough to get side effects from these treatments, namely urinary problems or sexual problems. Not everyone gets those side effects. Not everyone gets those side effects, and their quality of life is fine. But some do.
And if one was to even be one of those who got the side effects, are there ways of controlling those side effects as well to improve the quality of life?
Yes, there's lots of ways. For example, if the problem is erectile dysfunctions, in other words, the man's not able to get an erection such that he can penetrate, there are ways and means of dealing with that, whether it's tablets like Viagra, whether it's vacuum pumps, whether it's injections into the penis, whether it's a penile implant, for example. So there's lots of ways of combating the erectile dysfunction. If it comes to urinary difficulties, there's drugs that will reduce the frequency with which you have to pass urine. If the control of the urine is an issue, you can be taught how to do pelvic floor exercises to tighten up your pelvic muscles so that you're not leaking urine. Or if all else fails, it's possible to have further surgery where you can put a device in to keep your urethra shut so that you don't leak urine. So there's always something that can be done to improve the quality of life.
Thank you, Prof. And of course, if the cancer is cured, the other things are just things that can be sorted out. So someone should not stay away from cancer diagnosis to avoid those. Now, someone is asking, what about if we get out the prostate early, prophylactic prostatectomy, to avoid the risk? They've completed their family size. would that help prevent prostate cancer?
Yeah, so it would. It's a rather drastic thing to do. We occasionally do a prophylactic prostatectomy, occasionally in someone who's got a very strong family history. For example, all their brothers and their father, they've all had prostate cancer. Then occasionally we might remove that man's prostate, but it's uncommon. The reason it's uncommon is because you subject that man to the risk of those side effects of erectile dysfunction, of course, infertility, but which may not be an issue in the case that you said. But it's really the side effects that, if you're unfortunate enough, can be lifelong and debilitating to you. So that's why we don't do preventative prostatectomy.
And now someone is saying, if there's significant funding, about 10 million pounds per se, to improve prostate cancer outcomes in Black men, what would be your top priorities for that investment?
The priority has to be screening. It has to be screening. It has to be inviting all men above whatever age thresholds we put to have a PSA blood test. And if you do that, and we have done some small screening studies in the past, you will find men with early prostate cancer. And the treatments we have are very effective. In fact, the only way you can, in the UK, about 14,000 men a year die from prostate cancer. That's more men die from prostate cancer than women die from breast cancer, and those men die in the main because the cancer has spread. Something like 1 in 5 men, when we diagnose prostate cancer, it's too late to cure them. Although we can control it for many, many years, but we can't cure them. So you have to find prostate cancer, early diagnosis. This is a government national cancer plan mantra: early diagnosis, early diagnosis. You can only diagnose it early by doing as things stand, a PSA blood test. Now, in the future, we may do what we call a prostatogram, which is a very rapid 10-minute MRI scan, as well as a PSA blood test, and that may be where the future lies. But if I had money, I would start a screening study. That's what I would do. Not a screening study, a screening program.
Right.
We don't need more studies.
And with your experience with running such screening programs, someone's asking, how much do you think it will actually cost to fund maybe another one? I think we might have an investor in the audience.
That's a very good question. I can't tell you how much a national screening program would cost, or even if you just screened Black men, how much that would cost. I mean, a PSA blood test is about £10. Okay, so that would give you. It's not an expensive test, and the MRI is maybe £400.
Okay.
So as things stand, you could do it. If you screened men with the PSA blood tests, I think something like 3% of them it would be abnormal. Okay, so 97% of them you could say go away, repeat it in a year or two. Out of that 3%, then you would do an MRI scan, which is not hugely expensive, a few £100 for an MRI. Probably 2/3 of those having an MRI would not have prostate cancer. So you get down to maybe a rather smaller number who you will diagnose with prostate cancer, and hopefully those men who would find it early. So I'm not sure I can't tell you how much a screening program would cost. The National Screening Committee is looking at this as we speak.
I love that you said that, because someone's asking, is there any updates from the National Screening Committee on targeting Black men for screening?
Well, the committee met in November and decided and recommended against it. A lot of us, myself included, have made representations to the National Screening Committee. They had a meeting on the 26th of March, which was like a couple of days ago. but we've not heard the outcome of that meeting. So that meeting on the March the 26th was to decide whether they're going to be swayed by the representations by lots of different groups that they should be screening black men. So I don't know when they're going to make public what their final decision is.
And do you think there should be more effort into root cause or corrective, preventative actions regarding prostate cancer in Black men?
Yeah, if we knew what those factors were. So until we do, I mean, we can't do anything about being Black. We can't do anything about our age
or genes.
What we can do something about, we can't do anything about our genetics. And there are certain genes that have been identified as are more common in Black men than white men. So we can't do anything about that. What we can do something about is our lifestyle. It's what we eat and what we drink. So when I give talks in the community, I say somewhat tongue-in-cheek, cut out the McDonald's and the Kentucky and the Burger King, and I'm yet to be sued by any of those big corporations.
Okay, so we're almost getting through. There's an important question saying, if someone has a PSA of 18 and is scheduled for a biopsy, is there any contraindication or risk?
No, there isn't. That person needs a biopsy.
Right. Is there any special guideline for neurodivergent people with high PSAs?
There's no specific guidelines for that, no.
Okay. And lastly, someone's asking how they can be part of the screening movement in terms of donating, volunteering, committee members, trustees, people want to get involved.
I think by directly approaching one of these Black-led charities, like, for example, Cancer Black Care, which I know intimately because I've been chairman of that for a very long time. But there are others. In fact, one of the things I might do is compile a list of them for CALM, and then CALM can perhaps disseminate that so as people that are interested can contact an organization close to them. I think the other thing that is also worth doing is writing to your MP. You know, there's always political aspect to these things. You know, write to MP. One of the things that I'm encouraging CALM to do is have a men march down Whitehall, saying, we demand that this is taken seriously. You know, this is an inequity, and we're twice the risk, and yet there's nothing being done about that at all. True. So I think banner waving down Whitehall, petition at Downing Street.
Thank you so much for your time and for enlightening us all about prostate cancer. So for those in the UK, as well as those back home in Africa and Caribbean, what will be the most important thing they should take away from today, Prof?
Get your PSA blood test from the age of 40 on a regular basis. Okay,
you've heard it, everyone. Don't let an internal exam stop you. Get your PSA done. Thank you, Prof.
You don't need the finger. You do not need the finger.
Thank you, everyone, for tuning in. And I'll hand over to Abby. Thank you for having us all.
Thank you so much.
It's a pleasure to be with you this morning.
Thanks so much, Professor Frank, and to Dr. Chibuzo for chairing. I'm just going to share some slides just briefly to round off. So just bear with me a minute, please. So thank you everyone for tuning in today to Health Hour. Health Hour will return again at the same time next week, and we'll be focusing on Black maternal health, looking at culture and confidence through pregnancy and birth. So again, from 11 to 12, please do share with your networks and encourage people to attend. And we'll be learning a lot more about the key challenges affecting Black women's health during pregnancy and birth and building confidence. And the guest speaker will be a resident doctor, Dr. Priscilla Jan, who works in obstetrics and gynecology. So next Saturday, the 4th of April from 11 to 12. Please do scan the QR code to learn more and to register, or email info@can.org.uk. And the Black Healthcare Awards will be returning on the 4th of July to spotlight the brilliance of Black professionals in health and care. It's a celebratory event, and we really encourage everyone to attend and nominate those that you want to celebrate in the healthcare field. It will be in London, and it's a black tie event with a 3-course gourmet dinner and lots of distinguished guests and speakers. So we do encourage those who can to attend, and more information is available on the blackhealthcareawards.can.org.uk website, and you can use the QR code above to secure your ticket. The Black Healthcare Health Inequality Summit will return on the 20th of April at Blackfriars in London. It will be Can and the Inspire network supporting the health of Black Londoners steering this event. So it's a call to look at reviewing a lot of evidence and data that we know around health inequalities that affect our communities. We want to look at how we reach equity in health. So please do sign up to attend, contact events@can.org.uk and scan the QR code for more information. The Black Health Legacy Programme, we want to make sure that we're making sure that our voice as a Black community is involved in the kind of how we shape our health and care research, how we make sure our voices are included and represented, and to make sure that the studies that happen about us are for us, and how we make sure we're connecting the Black communities to research. So your voice does matter. So we really do encourage you, where you can, to share the online survey and to take part yourself. It takes about 15 to 20 minutes to complete. And if you've got any questions at all, please do contact research@can.org.uk. The Safe Steps programme is a free sexual health service directly targeting and for Black African, Black Caribbean, Latin American and other global majority communities across Lambeth, Southwark and Lewisham, to help make sure that you have the information and support around sexual health, and to make sure that you feel comfortable and able to access health services and conversations to make you feel comfortable around sexual health. So you can reach us at any of the community hubs, and there's more information on the slide there with a WhatsApp number to message or call, and you can also email the team at safesteps.london. And carbon monoxide is something that is a really important thing to be mindful of in our homes, and Can has been working alongside Cadent, the Your Gas network. Carbon monoxide has no smell, no sound, it's invisible and it's silent. So a risk, it's a really, really high risk, and something that's really important to monitor within your homes. And at Can, we've taken action distributing over 3,000 carbon monoxide alarms to families across our communities to help increase the awareness and make sure that we're really tuned in to making sure that our homes are safe. So it's about staying one step ahead, looking at prevention. So if you want to get involved or to find out more about this, please email the email on the screen there, or the number in the slide there. And for all of the information that I've mentioned, you can find out more on our website and also across our social media channels. So thank you so much to everyone for tuning in today. We really hope we'll see you again next week. Please do continue to join Health Hour on Saturday mornings and share with your network. And we hope to see you then. Thank you so much again to Professor Frank and to Professor Ijeoma.
And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.